Hi, my name is Mike Edwards and I'm the Service Delivery Director for the New South Wales Rural Doctors Network, RDN. I have the pleasure of introducing David Monck and Dr. Amanda Johns, who will be presenting on pain management. David is a clinical nurse consultant in pain management. He's been working in the field of pain management since 1998 and completed the Master of Science in Medicine Pain Management at the University of Sydney in 2012. As well as working at Greenwich Hospital Pain Clinic, David works as an acute pain service clinical nurse consultant at RPA Hospital. David's primary role at Greenwich Hospital Pain Clinic involves working with Dr. Amanda Johns to provide outreach pain management services to New South Wales Far West LHD. This outreach service includes telehealth consultations, video link group patient education sessions, outreach site visits, and training and education for local health district and primary care clinicians to build local capacity. Welcome, David. Dr. Amanda Johns is a pain and rehabilitation medical specialist. Dr. Johns completed her medical degree at the University of New South Wales. Dr. Johns specialised in rehab medicine and undertook training in Darwin, Brisbane and Sydney. Dr. Johns completed her secondary fellowship in pain medicine at the RPA Hospital, Camperdown. Clinical areas of interest include musculoskeletal pain disorders, including fibromyalgia and arthritis, cancer pain, spinal cord injury associated pain, and works in acute cancer and chronic pain. Dr. Johns is a project leader of the Greenwich Hospital Far West New South Wales Chronic Pain Telehealth Service, delivering a telehealth chronic pain service supporting local clinicians and delivering targeted education events for the Far West LHD. David and Amanda will now be speaking on pain management. Thank you.
Hello everyone, and thank you for tuning in for my talk today. I would like to express my gratitude to the New South Wales Rural Doctors Network Outreach Forum for inviting myself and David to speak today. I am doing a joint presentation with my esteemed colleague, Mr. David Monck, who is a clinical nurse consultant in pain management. So I myself am a pain and rehabilitation medicine specialist, and I currently work at Greenwich Hospital as the project lead of this service I'll be talking about today. I also work at RPA Hospital and Lifehouse Hospital, where I am the director of the pain service there. It is certainly a privilege to be able to share our experience with you in setting up and running the Greenwich Hospital and Far West of New South Wales Telehealth Chronic Pain Clinic. So the outline of the talk today, I'll be discussing the first 2 points, and the third and fourth will be for David later in the talk. So I'll begin by talking about the background to how the service started, and then what were the key components to the clinical telehealth service. I think resilience is the perfect theme for 2020, and certainly in the healthcare setting for this year. This is a definition I found on Wiki, but I thought it was apt and relevant, especially if you're setting up a telehealth service to the Far West or any region in remote locations. I think resilience, the capacity to recover quickly from difficulties, and even the second definition of being able to spring back into shape are both relevant. I think David and I have faced many challenges and felt rather overwhelmed at the enormity of the workload that we have faced, the complexity of the patients we've seen, and the limitations of available resources. It's only been through determination, the effort to continue, turn up, building local relationships, and the support that we've been given that we've been able to continue in our work. I'd just like to try and set the scene of where we deliver our service and where our clinic is. So we're currently in the Greenwich Hospital Pain Clinic, and I'll show you the map. So that purple arrow points to a location just off River Road, which is where we are recording this talk today as well. You can see that it's on the lower North Shore and a very urban setting to providing rural and remote healthcare services. So how did we get started? Back in early 2016, there were funding grants made available from New South Wales Health to provide telehealth chronic pain services to 3 primary health network regions. The 3 areas that were available were the Far West, Murrumbidgee and Southern primary health network areas. Our application to the Far West was obviously successful, and that's how we got started. So the Far West of New South Wales covers 194,000 square kilometres, has a population of approximately 30,000 people, the majority living in and around Broken Hill. There's a high proportion of Aboriginal people, up around 12%. Prior to our telehealth service, the locals would have to travel to Adelaide to be seen in the closest pain clinic, which is over 500 kilometres away. The wait times to be seen in Adelaide was in the order of 12 months, and I've since seen some patients that were simply removed from the wait list, having never been seen at all. The Broken Hill Hospital ran something akin to a chronic pain clinic, and they closed its doors the day we started and handed us an enormous folder of patients. So how did we actually set it up? There were 3 main components. We wanted to build local capacity to improve the skills and knowledge of the local health practitioners out there. We were endeavoured to provide an ongoing clinical service, and that was delivered solely via telehealth link-up. And it also included 3 visits per year to Broken Hill as part of the service level agreement. So what happened? Well, David came on board and we tried to work out how to set up the clinical service. We headed out to Broken Hill on a 3.5 to 4 hour flight on Rex with an open mind, but also no clear idea of exactly how to set up. The first visit was crucial. We wanted to get to know the locals and primarily get to know who and the how. The key organisations involved were the local health district, the primary health network, Mari Ma Aboriginal Corporation and Hammond Care, which is us. We decided that the clinic should be into the GP practices. There were various reasons for this. It would allow the GP or nurse practitioner to be present. It would improve the confidentiality for the patients at that end. And it would also have that appointment experience for the patient, seeing their specialist in a clinic room. It would also mean that the patients could remain in their individual GP practices and maintain that link to their GP. And that was an important local consideration that we weren't aware until we visited Broken Hill. Broken Hill has 4 main GP clinics and all are well resourced, and most were delivering telehealth clinics when we started in 2016. And they're all readily prepared to start incorporating our service into their local practice. David and I did consider the hospital setting, but we didn't think that we could get consistent staffing and traction to make it work. And we had heard that some of the Indigenous patients were not that comfortable to visit the hospital. And so we wanted to make it as accessible to all the local people. Referrals to the service are only accepted from a GP or a nurse practitioner, not from a specialist or hospital doctor. We do get calls from the hospital and other specialists, but we always refer them back to their GP to make that initial referral. The patient then has to complete an EPOC questionnaire, which is the Electronic Persistent Pain Outcomes Collaboration. And that's a 6-page document that the patient has to fill in themselves, and that gets faxed or emailed over to us. And then we book them into our telehealth clinic at their usual GP practice. The wait list at the moment would sit at around 3 to 4 months for a new appointment, but it has been at times up to 8 months wait, particularly during last year when we got a flurry of referrals. So this is our not very high-tech setup at work. That's David Monck, my colleague, who will be talking soon. And that you see is his office as well as our telehealth clinic room. And this is where we run our weekly telehealth service. We have just upgraded the speakers a couple of weeks ago from those two old fossils you see there. So this is what the patient would see at their end. This is the telehealth clinic at the Royal Flying Doctor Service, and that person sitting there is one of the GPs we've been working with for a few years. You might even see my face on the screen. Outside the window there is the tarmac for the RFDS service, and they do a lot of outreach clinics as part of their service, as well as the emergency rescue component of their particular service. So each week we see the patient. They're linked in via the New South Wales PEXIT platform, which is used in all the New South Wales health hospitals. But prior to that, we were using Health Direct, but that stopped being funded, and then we moved over to the PEXIT platform. There might be at the patient end, you could have the GP sitting in, their nurse practitioner maybe, an enrolled nurse, a registered nurse, or simply just the patient themselves or their significant other. It was a deliberate strategy by our service to provide as fewer barriers to engagement as possible for each GP practice. There's also quite a lot of behind-the-scenes organisation required to get the patients to arrive at the right location, to get the GP practices in the loop, that the staff at the front desk know that it's happening and have a room available. The patients are billed through Medicare billings. There's the additional telehealth billing code. And since the coronavirus crisis, occasionally we do telephone consultations as well. On the day of the clinic, I type a letter, David types a separate letter, a summary, and that's emailed on the same day. So the GPs find it quite a convenient service in that regard. So we started this service off focusing on Broken Hill and getting some success and traction there. But after that was happening in a regular fashion, we then decided to move into the smaller towns around Broken Hill, and we'd received referrals from those locations. So we now have a number of patients that we've seen at Wilcannia, Menindee, White Cliffs, Wenaring and Tibooburra. It's a similar setup to the Broken Hill GP practices. A contact is made with the remote area nurse. Initially we did test calls. We don't do test calls anymore. And the PEXIT platforms was actually already being used in those locations prior to our service using it. So that was quite convenient. And I'm just, for those of you not as familiar with those towns, you can see north, there's Wilcannia, White Cliffs, right at the very top, you can see Tibooburra, you can see Wenaring. So the RFDS as well as Marimar provide different clinics to some of those towns. And that's where the referral source has been. All the towns down south typically get their send their referrals down to Victoria or even Melbourne. So things that we've learned is that establishing those relationships locally is important. The clinical examination has been surprisingly unimportant, but when required, David and I have done a pantomime type arrangement at our end, sometimes facilitated by the RN at the far end, or the patient copies the actions required. Resilience has to come into play. There is a degree of frustration at the telehealth model of clinical care, but like I said, it's better than what the access that the local patients had, which was quite limited prior to this. And David and I see the patients together at the same time, which provides an efficiency in our service. So we have collected data along the way with those EPOC questionnaires, and I've just presented a small amount of that data here, which you can see. Certainly our service has been up and running for 5 years, and nearly all of our patients have been seen solely via telehealth. There have been about 4 patients who have turned up and we've seen face-to-face, and they've been in Sydney for various reasons. Our clinic has seen on average 80 patients per year, which would mean that we've seen over 300 people with chronic pain living in the Far West via telehealth service. Our EPOC data, as you see here, provides us with the information on the type of pain patients seen. The data confirms what I've experienced clinically, and we definitely see very complex patients. On average, they have higher pain scores. As you can see, that's 6.7 versus 6.2, and this compares our data to all the pain services in Australia and New Zealand. So you can see there that those pain levels are higher, and also that the pain degree of interference into aspects of your life is also higher. Our patients have similar levels of depression, anxiety and stress. There is higher levels than the other pain services see on average around pain catastrophizing scores, and a slightly lower pain self-efficacy, which is also a poorer outcome. Certainly clinically, that's the experience that David and I have seen in our weekly sessions seeing patients. There's also a high degree of unemployment seen in our patients due to pain, and also that these patients have had pain for more years. So I'd just like to hand over to my colleague David to continue the rest of our presentation.
Thank you, Dr. Johns. I'm David Monck, the clinical nurse consultant with this service. So, as Dr. Johns stated, our service level agreement requires that we do 3 outreach visits per year, and both Amanda and I organise and attend these visits together. We set different goals and according to perceived clinical need at the time, but on each trip we try to visit the 4 main GP practices in Broken Hill for either a morning tea, a lunch meeting, or just a drop-in and a chat. The whole service wouldn't have worked and wouldn't continue to work without the personal connection to the people in Broken Hill. It builds rapport and engagement. We invariably find a spike in referrals after each outreach visit. Education is a big part of each visit, and we run a PHN coordinated educational dinner 1 to 2 times per year, and we have had outstanding attendances. Between 30 and 50 people usually attend, and the audience consists of allied health professionals, nurses and GPs, and some have been particularly well attended by pharmacists. We have come to learn that GPs prefer case-based discussions, and we lead these discussions in small groups at their practices. Last year, our trip coincided with hospital nursing orientation, so I went up to the hospital and provided education to the graduate nurses on intake. I've also provided nursing education in service education as requested, and those topics have included chronic pain patients who are inpatients, managing ketamine on the wards, and general acute pain inpatient management. We've also acted in an advisory role to the LHD and to GP clinics for some policy development projects, usually around opioid stewardship and opioid prescribing. So from the very beginning, our service has tried to wean and cease opioids for chronic pain in line with best practice and current practice guidelines. We try to be clear, consistent, fair, and empathetic. Sorry, I'm just going to go to the next slide. So this is my setup at the YMCA in Broken Hill. I found a great room, the wellness meeting room, which is right in the middle of town, so it's easily accessible. I provide a 1-hour session educating patients about the nature of chronic pain and how it differs from other pain, and how management long-term is primarily non-pharmacological. The primary goal is to address the patient's expectations and understanding of their pain and their management options. This enables patients to engage better with GPs and explore alternative management strategies. A major part of the talk focuses on the patient's mood, mainly anxiety and depression, and how this impacts on their pain. 1 hour is not enough. It's not enough time to teach specific strategies like mindfulness or pacing, but it is enough time to introduce these concepts. There's a lot of power in holding a group session, as often a person with chronic pain is able to impart their experience and demonstrate to the others what effective pain strategies they currently use. And this is much more powerful, I find, than just a death by PowerPoint education presentation from me. I've been running these groups for 5 years now, and I quickly worked out that each group is different though. So I've learned to tailor my talks on the go to accommodate for the feeling in the room and the nature of each group. It would be good if there were more local group sessions that were professionally run, but unfortunately, this isn't the case. Being flexible has been key to my success and resilience in presenting pain education talks. Some of the methods of education delivery have failed. My first 2 attempted group telehealth talks had no attendees, despite a number of invitations being sent and morning tea being arranged. So I gave up on group telehealth education for Broken Hill at that time. I now only do face-to-face group education talks with each visit, and this works well and is much easier to facilitate. These sessions have been running since 2017, and I also learned quickly to overbook the talks. So I invite up to 30 patients with their relatives or carers, and I find that inviting 30 people gets between 3 and 10 people on the day. The room holds a maximum of 12, so that's good. As part of the clinic service delivery model, I also do individual telehealth sessions or phone sessions for some patients on a case-by-case basis. These clients are booked in to discuss their own particular pain strategies and goals. As our service covers the whole of Far West New South Wales, we can follow patients from GP room to GP room and even town to town. Several patients have maintained a consistent pain management plan coordinated by our service, even though they've moved quite a long distance. This also restricts the ability of patients to doctor shops. And on occasion, we've had 2 referrals for the same patient from different GP practices, even from different towns. General practitioners have given us good feedback and have often been willing to participate in the consultation, most often just by coming in at the end of the consultation and discussing the treatment plan. Trainee GP registrars often attend the entire consultation as part of their ongoing GP education requirements. There have been many highlights. Visiting Broken Hill and other surrounding areas have enabled us to develop professional relationships with the local practitioners, which has been very rewarding and enhancing. And we've been able to deliver a better service over time as these relationships have been developed. There have also been many patients who we think have done really well, and we've maintained a connection with these patients over a long period of time, and that's always professionally rewarding. Visiting the living desert sculptures 10 kilometres outside of Broken Hill at different times of the year is definitely a highlight at the end of a busy day. Thank you.
And so I'd just like to conclude our session there and thank everyone for tuning in today. I hope that everyone learnt something about telehealth and its importance to rural and regional clients, and can see what kind of benefit providing a consistent service over many years has been to the far west of New South Wales. But I'd also hope that everyone's inspired to continue to provide telehealth even beyond the current COVID crisis. It's been good to see some of my peers and colleagues having to learn these new skills, and I hope that this continues well beyond the current medical crisis that we're facing right now. And I hope that our rural and regional clients demand better access to specialist services as well. So thank you, everyone, and take care.